Welcome to the Love is the Cure Foundation podcast. I'm Alfonso Vega.
And I'm Lindell Vega.
On the Love is the Cure Foundation podcast, our mission is to create conversations that offer real value to families navigating the challenges of pediatric brain cancer. We aim to give families a clear understanding of what to expect at each step of their journey, from diagnosis to treatment and beyond, helping them feel more prepared and less alone during such an overwhelming time. On today's episode, we have Jaclyn Colgan, registered nurse at Boston Children's Hospital. Jaclyn was also one of our son Inigo's nurses on the neuro-oncology service. She is now a DMP, FMP candidate as she continues her education at Boston College. We are talking with Jaclyn today about a very serious and delicate subject, palliative care and end-of-life care. Jaclyn was Inigo's nurse from the early days of his cancer journey right through his final moments. Her compassionate care, along with the kindness and gentleness she showed Inigo, played an essential role in our experience. As she continues her own educational path with a focus on end-of-life and palliative care, it's clear that she's dedicated to this deeply meaningful work. Throughout Inigo's treatment, we saw her professionalism, strength, and unwavering commitment. However, in his final days, it felt as if her focus on helping us became even more profound. Perhaps it was just a parental perception, but her support seemed especially magnified during that time. We recognized that Jaclyn was always the consummate professional, but from our perspective as parents, her care during those final days was exactly what we needed as we said goodbye to Inigo. Today we are discussing a deeply serious and emotional topic, and while our feelings may be strong, we hope they won't overshadow the important information we want to share. Palliative care and end-of-life care are such tender and critical parts of the journey for pediatric cancer patients and their families. Our goal is to approach this conversation with the sensitivity and respect that it deserves. Jaclyn, welcome and thank you for joining us today. Welcome to the Love is the Cure Foundation podcast, and thank you for having this conversation with us.
Thank you for such a wonderful introduction, Alfonso. I really appreciate it. It's an honor to be here and to talk with you guys and just to see you again.
Thanks, Jaclyn. If we could just start off, can you share about your background and what led you to this field of nursing and where you're headed?
Yeah. So I think for me, I was always very interested in healthcare. Even from a young age, I just was always interested in sciences and learning about the human body and the human condition. And I think I knew I wanted to be in healthcare in some regard. But I think I started to become particularly interested in nursing probably in like high school, I would say. I experienced a bit of loss in my family from like quite a young age. And I think seeing family members in the hospital, I was never someone that was afraid. And I think I just always kind of felt comfortable and felt really, I kind of just was inspired by the nurses that I saw and the way that they were able to kind of just produce this sense of calm in such a, chaotic environment like a hospital. And I think I actually started on the neuro floor at Children's when I was in nursing school, and then continued as a nurse there. And as you said, now I'm in NP school and would love to continue, if able, kind of at Children's and in the neuro-oncology field and in palliative care eventually as well. But yeah, I think the biggest aspect of nursing that has drawn me into healthcare in particular is nurses are known for being like the caring ones that are at the bedside 24/7, that are, the point person for people in the hospital. And I think that is what's kept me going for so long too.
Thank you for sharing that. So one question that I have for you, and maybe you can explain to our listeners, maybe a little bit of the difference between, we hear what palliative care, we hear it thrown around a bit in healthcare, and sometimes don't understand that there might be a difference between that and end-of-life care. Can you help us understand the differences between the two?
Definitely. So I think palliative care we talk about is really, it's focused on symptom management. So it's not specific to oncology. We see palliative care used for all different conditions. And I think what we talk about is when a child is diagnosed with a chronic condition, something like cancer or heart disease or other conditions, palliative care is considered like basically just a tandem team that can help manage symptoms throughout the course of their treatment. I think people often think of palliative care as a synonym for hospice care and end of life care. And I think, especially at children's and in pediatrics, we try to steer away from that because it's really not the same. And specifically in a lot of children's hospitals, they don't actually call it the palliative care team, in case anybody didn't realize. But so at children's, it's called the PAC team. We kind of use that synonym so that people aren't afraid to hear palliative care. And we always talk about specifically in oncology that palliative care should really be consulted on like day one of diagnosis. And I think specifically for our brain tumor patients, their symptoms and their treatment is very complex. And it's not the typical trajectory of someone diagnosed with cancer. And I think that palliative care specifically can really help with complex pain. They can help with other symptoms and not just supporting the patient and the child, but also really being there as a support person and someone else for the family to just talk to on a day-to-day basis.
So with palliative care, is palliative care, it's throughout the diagnosis, is that right? So even if it's, like you're saying, not tied to end-of-life care, it can be given throughout, is that correct?
Yeah, that's correct. So I think, and that's where we see our palliative care team come back in a really stronger presence for patients that are brought into the hospital for end-of-life care. But we see a lot of families who utilize our palliative care team throughout the diagnosis. And some families appreciate it and really need that extra layer of support. And for other patients and families, their care can be really managed from the primary care team, which may be the neuro-oncology team or whatever the child's primary service is. But palliative care really can be used throughout the cancer diagnosis. And they can really just help manage different symptoms, and whether that's different symptoms that come up throughout someone's diagnosis. But I would say at the end of life, they are particularly helpful at also helping assist and manage symptoms that come up.
And I want to apologize. You just said it's called the PAC team, and I referred to it again as palliative care team. So I apologize about that. I was listening, I promise.
It's the same thing.
Okay. I'm going to see myself through all the emotions of this conversation. So I promise I am not foggy.
That's okay. We can use them synonymously here today because in other places,
they are synonymous.
Yeah. In other hospitals, they may not call themselves the PAC team.
Mm-hmm. Yeah.
They might.
Yeah. I love that. What you're saying is, and I think I like this for kids, for pediatric patients, that it's not called or not necessarily called palliative care. Because I think as a parent, that if we're truthful with ourselves, we know the numbers and what we're looking at when it comes to brain tumors. But it's still good to not call it palliative care. So I like that.
And I think it was mostly designed in that way because, I think for too long, palliative care, especially in adults, was always seen as like, oh, if they were bringing in palliative care, that means this patient is approaching the end of their life, which is not the case. So I think they tried to kind of create a new way of introducing themselves so that parents weren't kind of afraid of that stigma of palliative care being synonymous with end of life care.
Yeah. Okay.
Yeah. I guess I have a couple examples for our listeners if they're wondering, like, well, what is an example of this? For Inigo, earlier in his diagnosis, maybe month 2 or 3 after his diagnosis, the PAC team had come in and done an assessment of him, and he was having difficulty with sleep And, at the time he was going through radiation, so he was having to take a lot of sedatives to help keep him calm through these treatments. And, just keep him very relaxed during those things. And, it had lasting effects. So he'd nap through the whole day and then maybe be up all night. So they thought, oh, well, maybe there's a little bit of delirium involved here. They tried to come up with creative ways to help cue him when it's daytime. Obviously, we were doing things to help cue him that it was daytime, like keeping the windows open, keeping lights on during daylight times, cueing him when it's meal times, those types of things. But they gave us an alarm clock to kind of help cue him if we put it next to his bed where he could see it light up in the morning, or if he would know that morning is coming, or if it was still darker, he would realize that it's just not time to wake up yet. So these were all creative ways that they tried to help him orient to the day. So this was one step that they took for our son.
I think for someone like me that is not in the medical field, as both of you are, when I hear palliative care, I think medicine. I think medication. I think pain management medication. So I guess I wouldn't have equated other strategies outside of medication as also palliative care.
Yeah. I appreciate how creative they were able to get, how they were able to go above and beyond maybe what the daily medical team who did rounds could do. They didn't necessarily have, it's not that they didn't have the time, it's that, that's what the PAC team is there for. They're there to think of other, alternatives that could be helpful. So I really appreciated how creative they were able to get for things like that.
Now, the strategies, obviously, Jaclyn, for in the difference between a pediatric patient versus an adult patient, you have much different strategies. Is that correct?
Yeah. And I think it's just very different when you have a kid that's in front of you. And like you were saying, Alfonso, I think you're not wrong in assessing that palliative care and PAC teams, they're known for pain management and helping support with medications and things like that. But I think, like you were saying, they are also very creative and can come up with unique ways to help kids in all aspects of their time in the hospital and even outside of the hospital. But I think, it's very different in adults because, adults, they don't always necessarily need the same types of support that children do. And I think, we equate older adults with that's a normal process. People grow old and we all, have limited time here. But I think with kids, it's a little bit different just because it's not typical. It's not normal. And I think naming that and, finding ways to creatively support kids and also their families is really important.
I like what you said there. It's not normal. And I think for parents that would be listening, I think it's really good for us to accept that this isn't normal. I think in so many ways, when your child has cancer, you normalize things that doesn't make sense for you to normalize, right? Your child shouldn't be dying of cancer, and yet here we are, and we have to deal with it. But I think if parents can still hold fast to the idea that this isn't normal, we cannot normalize cancer. We can't normalize that our kids die from it. I like that you said that it's not normal. I mean that in the most sensitive way. I still don't, in very many ways, accept that our kiddo, died of cancer. And I think it's so powerful to have teams around you that are willing to be creative in how to figure out pain management for your children. But I think it's also important as parents to realize the service that it provides you. So I want to go back to something that you said, Jaclyn. You became a nurse for there was many reasons there, but I really like that idea of the person at your bedside, right? The person there, the presence that was with you, and that was something that motivated you in moving into this field. And I think for all of us, when we're sick as children, when we're going through different things, we want someone by our side. We want that comfort. We want that person that is going to give us that care that we desire.
Mm-hmm.
And I think for parents, a palliative care team is so important because it offers that to us while we're trying to offer the other to our child,
Mm-hmm. And I think it's important to be said that, offering this palliative care to a family, to a child, it must require some special kind of courage. I mean, because you guys are able to face this head on and help the family face this head on as well, because that is a process for the parents and the child as well. And, we may just not
Yeah, we're not when
have
it's
the
your
strength.
child, you're not set up with the capabilities to be able to process this. And so to have people around you that are literally there to help you process these moments, it's like Lindy is saying, it's really it's just a special field, like that courage that's necessary. And I just want to I don't want to get too personal here either with you, Jaclyn, but you were so stoic with us as we were. You were with us that entire last 2 months, and you're so stoic about it in the most compassionate way. I think so many times when you talk about stoicism, it means like someone doesn't care, and that's not at all what we saw within you. It was more like
Empathy.
yeah, a stoic empathy. Yeah, I like that. It was you saw what we needed, but you met the medical needs first, which is really what we wanted. But yeah, I think it's important to have nurses, teams around you that are willing to not only move when action is needed, but be stoic and understand that in that moment, you are sort of our backbone. And I don't want to.
Family needs to borrow some of your strength.
Yeah, and I hate to put that on you because I know that's not your job either. You're not there to be our strength for us. It just happens that that's what you did for us, and that's in your character. And I think that that's really important in palliative care. And I doubt that that's something that is required of nurses when giving that care, but I think it's important that that's what we received, not just from you, but from the teams there at Children's.
Yeah, I think people don't go into pediatrics for no reason. I think it's really hard, and it's hard seeing kids who are sick, but it's also one of the biggest aspects of pediatrics that we talk about is also managing the family and being there not just for a young child, but also for their parents, for their siblings. It's the whole team, and I think to be able to do that is a special part of my job.
Yeah, and you guys do an amazing job at Children's Hospital, meeting our needs. We felt it from top down. We felt it from bottom up. We felt it from everybody. It was really, really something necessary. So once again, going back, so palliative care can happen from diagnosis to end of life, and they don't necessarily have to be tied together. Palliative care is really the alleviation of pain or the alleviation of suffering.
It's another example we could use and share with families is that, Inigo received palliative care in the sense that, he had received radiation early on, the first 3 months of of his journey, and he received a lifetime dose. So essentially, receiving more radiation after that, if needed, would not be curative. It would just be considered a route to
Pain management.
for pain management, to shrink other tumors that may crop up, and which he did end up using, like a couple months before he passed. He did develop more tumors down in his spinal cord, for which he needed some more radiation. So that radiation, in a sense, was considered a palliative treatment. It wasn't considered curative because it was just, he's already above the dose line of what could cure the cancer. It was just to alleviate pain and pressure and those sorts of things. Am I right, Jaclyn?
Mm-hmm. Yeah. And I think that's kind of like you were saying earlier, it's a really hard pill to swallow, right? Is when we start as the healthcare and medical team, like, acknowledging that the options for curative treatment start to dwindle. And I think, again, it's like people hear palliative radiation, or we sometimes talk about like palliative chemo, and it feels like, it's the end. But I think kind of our job at nearing the end of someone's life is reframing that, and acknowledging that, yeah, right now we're not focusing on cure, but we're not giving up. I think people hear palliative radiation or things like that and think of us as giving up. But I think you have to, and our job is to constantly help support families and patients to understand this, of like, we're not giving up, we're just shifting our focus, and we're focusing on their comfort and their alleviating pain and alleviating suffering so that they can continue to live and live comfortably until the very end.
Now, how do you communicate that to parents that might not understand that? So if a parent is already, and we've talked about this before in other episodes, your nerves are already so shot and you're so nervous about anything at this point, especially, I think through the middle parts of a cancer journey, I think a parent kind of gains some strength, right? We gain a little bit of understanding. But when we get to the part where we're running out of options, that strength really dwindles. And we don't have the same abilities to process what our child is going through anymore. How is it that you communicate your objectives?
Yeah, I think it's really hard. And I think it's really hard because parents, you should never give up hope. You know what I mean? Like, it's your child, and I think that is your job, right? Is to keep rooting for them and keep fighting. But I think as medical professionals, right, we too have hope, but I think it's a really delicate balance of having that and also acknowledging the really tough reality that's in front of us. And I think it's our job to remind families and to have, we often talk about like team meetings where it's getting everyone in the room, right? It's getting the parents, if the child, if appropriate, the nurse, the medical team, it might be palliative care team, all in the same room to kind of have this supportive conversation. And, I think sometimes parents may leave and it still doesn't sink in. And I don't think it ever really does, until it happens. And I think that's okay. And that's normal. And I think our job on this side of it is to be really sensitive and really delicate, but also be honest. And I think it's a really fine line of managing both. But our job is always to support you guys and the patient and the families, and do that in a way where you guys feel supported, but also, can grasp the really tough reality that's in front of us.
Well, are there any other special skills or qualities of that nurses need to have in order to be in this every day? I want our listeners to appreciate like what it takes behind the scenes to support families and children.
Yeah, I think a lot of it is things that, come natural to us. I think there are things that are hard to learn. I think it's just some things that are innate to who we are as people. And I think, like you were saying earlier, it's like, it's this aspect of empathy and, I will never be able to put myself in the shoes of parents losing a child. I think that is not something I have experienced, but, and I know we've talked a little bit about this, but like I lost my mother to cancer when I was very young. And I was just out of college. And I think for me, that experience allows me to do this work, and it is the reason I do this work. And I think you see the empathy that others, demonstrate to you. And it's this just knowing like this is what people need, people need to be heard and seen. And I think, I see this work as accompaniment. I don't think it goes beyond nursing, and I think our job is to just be there and accompany, young children and their parents and their siblings. And it's not just about the kid in front of you anymore. It's about everyone. And I think to be able to do that is really hard, and it's not easy work. But I think, to be able to just sit and listen and, like you were saying earlier, I think, yes, our job is to be there and to address the medical concerns and be quick on our feet and assessing patients and things like that. But it's also about just being there. And I think, that's something that I've grown into, and being able to just be, and not fix, not cure, right? But to just be there for a parent, in the pain and in the confusion and in the grief and just listen.
I mean, this isn't going to be helpful to parents, but I'm just amazed by this. It's almost like, I mean, I don't know if we have any other professions in this world that are about efficiency and your emotions, efficiency and what you can emotionally offer to that job, to that position. And so, I just find it incredible, especially with pediatric nurses, what you're able to offer us as families going through a process that is painful from the very beginning to the very end. So I hate to get into conversations not really about helping our families out, but I am amazed by the work that you guys do. I know we've had conversations about that, and I continue to say it to anybody on your team that I can, that we're just so moved by your abilities to compartmentalize your care for our child, but also your care, empathy, and love for us as a family.
Mhm.
And I think that that's something really, really special about pediatrics. And sorry, mom and dad, my parents are both adult nurses. And so I understand their empathy for their patients and their love as well. I just mean, we saw it in real time what pediatric nurses do for their patients and their families. And it's incredible work, and you guys should be celebrated for what you do.
Absolutely. So, maybe this is getting into like the details of what it takes to provide end of life care, but what would you say are the primary responsibilities or the primary concerns that you have as a nurse in providing end of life care for a child and their family?
Yeah, I think kind of as we were talking about, like once we've determined that, we're shifting our focus and really focusing on providing comfort at the end of life, it's different. I think it's less about the day-to-day, medical aspects of care, and it becomes a lot more focused on comfort. Um, and as the nurse, we often talk about end of life care in regards to comfort care. And I think our number one priority is always just keeping the patient comfortable. And I think as the nurse, you're constantly assessing your patient. And, again, that might look different. It might look, a lot less like, doing a thorough and detailed assessment of your patient, and more, focused on looking at them and seeing, are they in distress? Are they having trouble breathing? Do they look like they're in pain? for kids like Inigo, right? He was a very smart boy and could always tell us what he was feeling. And, I think even until very close to the end, but I think, our assessment of people changes. And, when someone's not able to express those things anymore, we're looking at the little details, and paying attention to those things. And I think constantly just checking, like, does he look like he's in pain? Does he look like he could use a little extra support with his breathing? Is there something we could give him for this kind of this fear or anxiety that he seems to be experiencing? I think paying attention to all those little details of how we can really make someone comfortable. And I think our job, and we talk about in nursing a lot, is this idea of alleviating suffering. And, especially at the end of one's life, no one should have to suffer, right? We can treat those things. And I think that's our number one priority.
Yeah, just full disclosure for our particular journey. Inigo fell into what could be considered a coma for the last 11 days of his life. And like Jaclyn is communicating here, the teams made sure to watch him, to observe him, and to assess what his needs were, even though he couldn't communicate those last 11 days with us. So whether it was, as Jaclyn is saying, is he having trouble breathing? What does his skin tone look like? Those sorts of things were really important for the assessment. But beyond the end of care for Inigo, it was looking at us as parents and turning off our monitors, letting us or communicating to us that it was no longer necessary for us to. It was never necessary for us as parents to keep track of the telemetry of what was going on, but we just did, and I think every parent does. You're always through your child's journey of cancer, you're going to learn what different things mean on that monitor, until the day that they move those monitors out of the room and you can no longer look at them. I think as parents, it's just natural for you to want to know what's going on with your kid. And sometimes the easiest way is to look at those monitors and to see a heartbeat and to see oxygen rate and all that sort of stuff. But for those last days with Inigo, it was communicated to us about it just wasn't necessary anymore. And I have to say, for me, it honestly, for the first day or two, it felt like a loss. I was losing my last connection of understanding what was going on internally with Inigo's body, just because for so long we had been paying attention to that for 20 months of his life, but it goes away, and probably at day 9, I'm okay with that. It becomes solely about being with my kid, holding his hand,
playing music, talking to him,
rubbing his feet, which he loved.
Still, providing that daily care to him.
Yeah.
Bathing him.
Brushing his teeth.
Yeah.
Combing the little hairs he had. But yeah, I just, for full disclosure, I just want to, excuse me, when Jaclyn talks about the assessment that a nurse does at the very end, I think it's so important that a lot of that assessment is also the assessment of taking the unnecessaries out of the parent's hands and enabling the parent just to be a parent.
Yeah. It was also really comforting to have that bed that they put him in. They put him in a larger bed, so that we could be right next to him.
Yeah.
And that was...
Yeah, it was great. So you could lay next to him, and I sat at his feet, and we just hung out and played music. But I don't know how much of this podcast people are going to hear because my voice is terrible right now, and I apologize for that. But I think, and of course, we bring Jaclyn on to probably our most difficult episode so far, but we appreciate that, Jaclyn. We really do. We knew that you were the the one to be able to handle this episode, and so we just appreciate your ability to talk to us about this. So, the differences between end of life care and palliative care, they still cross over, I'm going to assume. And so, in that assumption, I'm going to leave it to you. How is it that they cross over, and what are the important aspects for a parent to think about as those two cares cross over? Because they're not the same.
Yeah, I think it's like the square is rectangle, rectangle, square. Like they overlap and they, can do both, but I think they're also very separate, like we've talked about. And, I think towards the end, palliative care can be so helpful, and they, in the background, which I think parents may or may not be attuned to, is like they're usually the ones guiding a lot of our treatment. And I think, if it's the middle of the night and things start to change, and as the bedside nurse, we're not really sure, where to go next, how can we manage these symptoms? Our palliative care team is our go-to, and they are really helpful in terms of supporting us and supporting families and making quick decisions and changes that are necessary. And I think, they are the same in a lot of ways towards the end. And I think, like we talked about, it's just really important to make the child comfortable and also support the families. And, as like the palliative care team, and they come in, and right, becomes less to talk about with the patient, right? But it becomes more important to also talk to the family, and check in on the two of you and see how you're doing, and see what we can do, and like you were saying, it's the little things, bringing in a bigger bed, doing things to make it feel as comfortable and as homey as possible when you're in the hospital. Nobody wants to be in the hospital, but I think, allowing us to do the work and you to be there and be the parent to your child is all we can try to do.
So for me, if I had no idea how this journey was going to go, what I wanted to understand was, how was Inigo's pain going to be alleviated? So many times we talk about, or not many times, you just spoke about the strategies for alleviation of certain things. And it was whether Inigo needed an alarm clock or just those other strategies. There are strategies outside of, I guess I would consider those holistic. I would, so I just want to move into just a couple things just for other parents to understand. You're going to move beyond holistic needs because they're going to not work anymore, or they're not going to fit the needs of a child anymore. And you're going to move into needing medication. Mm-hmm. What does that look like? How do I, as a parent, understand the communication about it, about the medications that your child may go on, and what are the different strategies that the PAC team, the pain alleviation team, what are the strategies? What are the assessments? I guess I'm not really asking for a list of medications, but how would you communicate the need for much stronger medications to a parent that doesn't understand what it is that we're talking about when we say stronger medications?
Yeah, I think this is where we have to cater our care, because every single family is different, and I think we have like in the back of our head, we have this wheelhouse of things that we can offer, different medications, whether that's things like morphine or, and that can be given as doses, or it can be given as a continuous infusion, and what we call a PCA, which is patient controlled analgesia, which can be common at the end of life. And there's a whole slew of other medications, different anxiety medications, things to alleviate, respiratory distress. We have a lot of options. And I think our job is to figure out, how much the parent and the family want to know and need to know and want to be a part of. Because I think, there's so many families we see where, like, for Lindy, she is a nurse and knows so much and can talk to us in a different way than a family who might not have as much medical knowledge. And of course, our job is to teach families these things, but it's very different when a family member or multiple family members are really knowledgeable about medicine. And I think, some families may want to have a lot of say in what goes on and what decisions are made, but I think you also have so much on your plate. And I think, it's finding and figuring out, like, do you want us to take the wheel, and manage this ourselves? And I think that takes a lot of trust for families because, you were constantly the one behind the wheel, making the decisions, right? Guiding, right. As a medical team, we're always here to present options, but I think, right, it's parents' jobs to consent and agree and understand treatment and be in full understanding of what's going on. But I think at the end, it becomes different. And I think, we can say, like, we can address this, right? We can address this really complex pain that he seems to be having, or we can help him feel a little, less on edge, when we can see that a patient is kind of experiencing anxiety or fear or things like that, and every family will be different. Some families will want to be a part of that conversation. And I think that's wonderful. And I think it's also not necessarily required, and I think that's where, if you feel as the parents that you really trust your team, then, like, let them do their work, and they can help make your child comfortable. But again, I think it's a unique situation and it takes a lot of trust. But I think there's so many different options, and we see every single one of them, and based off of different cultural or religious beliefs, people want their home pastor or someone else to come in. And I think we welcome and invite all of that. And we work together to create the best situation for our patient in front of us, and no two children and no two experiences ever look the same.
Yeah. Yep. I can appreciate that too.
Yeah. So the pain pump, PCA.
Mm-hmm.
Oh, so important for us and Inigo. It just gave us a sense of alleviation to know that we had a little bit of control over that. But I do want to touch on something that you said too, about the necessity to establish a trust with your teams. Now, I know for us, once again, getting very personal about this, but because Lindy is a nurse, she did take on, and I expected of her, to take these things on too, because I trust her as a nurse, to make a lot of decisions through that 20 months. And it did reach a point at the very end where I felt that responsibility needed to come off her shoulders. And I know that we communicated, or I communicated that with the team. I know Kate and I had this conversation, and Inigo's MP on the floor, where I just wanted Lindy to be able to be a mom. And it's tough because up until that point, I wanted her to be a nurse too. Just because, I mean, it's like Inigo had a secret weapon at home with him when he was sick. He had someone that could assess, make decisions, move quickly, in a way that I wouldn't have, maybe because I didn't know. But we definitely got to a point where we had to put our entire basket of trust and hand it to you as a nurse, as your team. And so I really, really appreciate that we were able to have the relationship with all of you that enabled us to feel safe in that moment, because we really needed to just be a family at the end,
Yeah. And I think having that option of having you guys there for us in that moment was was the right option for us as a family. It felt right. I did need, some reprieve just to be mom. And I can completely understand why other families may opt to be at home. The child may really want to be at home. It's their favorite place in the world. That's fine. But
yeah. Inigo wanted to be at home. We, as parents, felt safer being on the neuro-oncology floor. And the reason we felt safer, the reason I felt safer, and the reason why I really pushed back on the idea of hospice care at home is because Lindy's a nurse, and I felt it more detrimental because I know even if this wasn't laid out in stone, Lindy's always going to be viewed as a nurse, and she would have been treated as such here at home. And I didn't want that to happen. I didn't want her last memories to be about medical decision making, and relying on her medical wisdom to give medication, to make decisions on that. I just felt that what you all offer at the hospital is faster. When we needed medications changed because either he wasn't handling them well, you were on it. And not only were you on it, you would reach right out to the team who needs to make this decision. That decision gets signed off on, and away it goes. And we didn't have to make any decisions on that, Now, just because of the way we are, we would observe him breathing differently or acting differently or whatever it was. And of course, Lindy's assessments never stopped, and it was still like, hey, Jaclyn, what do you think about this? And you guys would have a discussion because you guys speak a different language than I do. And then other decisions would be made. And that was fantastic because she was able to do that. But I want to, as we have this conversation, and as we divulge what a secret weapon you are, Lindy, I don't want other parents to think that that's necessary.
It's not.
Because it's absolutely not necessary. You guys can all be like me and not know anything. And then your teams are still there to be rock stars, to be just the amazing people that they are. And they're still going to take care of you as well as we were taken care of. So as we have these discussions about you, I don't want other people to misunderstand that you don't have to know anything. And your teams at the hospital, your PAC team, your nurses are still going to be the amazing people that they are.
I think the vast majority of the people we see are more like you, Alfonso, and they don't have experience in medicine, but I think the unfortunate reality is that you become just as well versed as anyone else, and you are the expert on your child, and you know them best, and that's why we work together, because I may see one thing, but you may see something else, and you know them, you've known them their whole life, and we just get to see a glimmer of that. So I think, we're there to teach parents and educate them about what we're doing and what interventions are needed. But at the end of the day, you guys are truly the experts.
Yeah, I definitely wanted to be an advocate for Inigo. I just didn't want to be an advocate in the wrong way. I didn't want to make decisions that would be detrimental to his care or to any of what you guys were feeling was the correct direction to go. So I'm just so thankful for the conversations that the medical teams were willing to have with both Lindy and I, and if it was questions that we had that maybe you knew that there was someone that had a more in-depth answer. For instance, I can just say we had deeper questions about radiation at the end, just for pain alleviation, that sort of stuff, and the teams communicated with us. But then all of a sudden, Dr. Elwani comes over from radiation, and he sat down and talked to us and communicated, and we had great conversations, and then we understood it in a different way. And I love that you guys you utilize each other, and then you also utilize your teams throughout the hospital too, that can also give a parent a deeper understanding of what is necessary or what could help in the alleviation of pain for your child. And so I think that's really key in how you guys make sure that you search out what is best for your patients' needs and for the parents' needs as well.
So if I may, Jaclyn, can we ask you a little bit about some of the emotional impact that you experience as a nurse, having to deal with this stage of life? Maybe you could share some of the things, like what has been the most challenging part of this work in oncology and having to provide the end of life care.
Yeah, I think the reality is that it's really hard. It's hard work, and it is work that I think is not meant for everyone, because it can be really hard to separate and to go home and leave work at work, right? Because, the truth is that we care about these kids, and I think recognizing that and naming that is important, because it does impact us, as I think it should. I think if it didn't, that would be quite strange, and I think it can be really hard, and oftentimes, and like we've talked about, we try to keep your care team familiar at the end, and try to have the same nurses and same people, just so that you feel safe, and I think that is so wonderful and such a important thing that we offer. But I think it also becomes really hard, and it's like in a good way and in a challenging way. It's work that we love and we care about as nurses, and we wouldn't do it if we didn't care. And I think we have a really great team, and I think it's work that you have to have really good people by your side. And we work with amazing families and amazing kids, and that is so special. And I think it's just as important to have really good coworkers, and as you know, we are lucky to have really good coworkers and people that we can lean on at work and turn to, and not just at work but also outside, and say, hey, today was really hard, like let's go out and get dinner afterwards and just talk about things, and having that, and having people who see that, and witness that and be there with you in that, I think is so special.
Yeah, this is such a delicate and tender time in the journey of parents with their kids. And I wanted to be careful with this little conversation that we had, because I don't want anyone to think that their stories are minimized. I know, as both of you know, my coping mechanism is I talk a lot. But I also laugh a lot, sometimes inappropriately. But it's definitely one of those, this is definitely one of those conversations that I think it is good to have for parents to understand that this is obviously the most sensitive situation that you're going to go through, because through the entire cancer journey that you have with your child, it's about fight, it's about hope, it's about faith.
Yep.
It's about motivation. It's about your community around you. But you reach this end of life portion, and it is special in that you are going to go through something that will live with you forever. And it's going to be in your dreams. It's going to be in your conversations. And it's such a tender and heart-filled moment.
Mm-hmm.
And you really, really, really do want to make sure that you live every single second of that portion of your journey in a sensitive and careful way.
Mm-hmm.
because it's never going to leave you,
Mhm.
right? And it's why I was scared to have this conversation, because I don't want to, in any way, shape, or form, through the way I communicate or the way I interact, to seem insensitive to how painful this moment also is. And if we're all honest with ourselves, it's a moment that cannot be macro analyzed enough, because it is so tender, it is so sensitive, it is so, these are the final moments that you have with your kid. And it's something that, for me, it will I will always appreciate how the hospital and the care teams gave us what we needed to just be with Inigo, to just hold him and just take care of him, without any other real interference. And I think that's so important about end of life care. It's the sensitivity that your medical care teams know to have, to become hands off, where they're still your medical care teams. They're still doing things for you, but they're kind of out of sight, out of mind now. And it's the only time that you're going to want that. It's the only time where you don't need therapies to come in and work out your child. You don't need people to come in and hang out if you don't want them to.
But you might just need them on standby.
Yeah. And so it was one. I mean, obviously we're weirdos, and we wanted all of you guys with us, and we did. We were able to have every nurse come in there, because we just love you guys, and hang out and talk. And but yeah, I don't want to minimize how important the end of life care is, and the importance that, as a family, this doesn't need to be said to any family losing your child, but make it only about yourself. Don't make it about anybody else. And there may be people and there may be systems that want to, hey, I want to come, be with you, or be with you do what's right for you
And your child, yeah.
and your child.
Mhm.
And if that doesn't work for you, and you just want to be with your child, you get to just be with your child.
Mhm.
So, Jaclyn, sorry to just leave that there, but I do want to ask you in closing, because we have kept you long here. What would your advice to parents be? And I'm sorry if I took any of your answers.
You did take my answers a little bit, but it's because you're right. I think it's such a delicate time. I think, as we talked about earlier, it's not normal. It should never, you should never be put in this position. No parent should ever be making these decisions that you had to make, and I think my advice to parents is to just be their parent. I think let us, once it gets to that point, handle the rest, because you, right, like, your time with your child is fleeting, and unfortunately you get to a point where you realize that the days are numbered and time is running out. And I think that is an impossible reality, and I think naming that and recognizing that, and just letting the parents be there. Let them lay with their child, let them hold their hand, let them be, and I think we can do the rest, and don't be afraid to make your needs known, right? I think you guys did a really excellent job at doing that and saying, like, hey, like, this is what we need, and as a nurse, we'll continue to ask, right, what can I help you with? What do you need? But I think, you know what you need. And really all that is to be there with your child at the end. And I think, that is the biggest challenge of figuring out too, like, is it worth it being in the hospital at the end? Is it worth it to go home and be in our space, right? But I think the hard decision is that when you're at home, it's all on you. I think, of course, there are going to be other supports and hospice care that can come in, but the day to day, the minute by minute, like those decisions are on you. And some parents want that and want to be in their space and, can take that on. And I give those parents so much credit because it's a lot, and our job as nurses, as NPs, as healthcare providers is to do that work, and when your child is in the hospital at the end of their life, to just let you guys be their parent, and that's it, and I think that's how it should be. You shouldn't have to be responsible for every single decision and every single medication that needs to be given. And I wish, hopefully we can get to a point where hospice care at home can be more supportive for families, because I think it would be a beautiful thing to be able to have both, but until we get there, I think there are both, good options, but you have to decide for yourself what might be best, and realize that we are here to support you and be there for you through every single step of that process.
If we could have been here at home with him, where it would have made sense for all of us, I think we would have wanted that. But it just made sense to be with you guys. It made sense to be in that space. It made sense to Inigo was diagnosed there, and we wanted it all left there. We didn't want to bring the end here either, especially to a place that Inigo absolutely loved so much. Jaclyn, thank you so much for being with us. You live in our hearts. We care about you so much. You were there, the night, 2 a.m., when everybody, needed to talk to Lindy and I and to figure out if there were any more decisions to make. And we had decided that there weren't any more medical decisions to make. And you were there, and Doug was there, and you saw us, and you listened to us speak with the surgeons and to make that decision. And we talked about it later with both of you, and you made us feel like we were understood, like our decisions were valid and important. And so these are moments that we're going to have forever with you, and know that you were there to hear us make some of these decisions that we never desired to make. But because of who you are and because of the empathy in your heart, you were just so wonderful to us, and you were so wonderful to Inigo. He loved you so much until the end, when the chemical imbalances just didn't allow him to really deal with anybody very well. And that is what it is, but just know how much you mean to us, and we absolutely appreciate who you are. And we just want to thank you so much for being the amazing person that you are, beyond being a nurse, because that's not the only thing that defines you. You're an amazing person, because it takes an amazing person to be an amazing nurse. And that is who you are to us, and so much more. So until we get to see you again, thank you so much for joining us today and going through some of these difficult conversations. And but you mean so much to us, and we appreciate you. Thank you.
Thanks, Jaclyn.
Thank you. The feeling is mutual.